Yes, you can start.
Thank you for allowing me to present. I bring you warm Southern greetings to you from the state of South Carolina. It's an honor to be able to participate in this webinar with Dr. John Davids and Dr. Pruitt. We begin this webinar with the assessment and rehabilitation of the upper extremity in children with cerebral palsy. Our objectives will introduce and review assessments and functional classifications in children with cerebral palsy, to the Shriners Hospital Upper Extremity Evaluation, or the SHU, and then we will apply the SHU and discuss the rehab with 2 case studies. In both research and clinical practice, clinicians use a multitude of different assessment instruments to evaluate hand function in children with CP. We use these assessment tools and functional classifications to guide our treatment planning, measure the efficacy of the intervention to improve hand function and prevent secondary complications and deteriorations, to discriminate between subjects, and to provide an avenue for longitudinal monitoring. However, choosing the right tool can be complicated. We must use our knowledge base of assessments and classifications and then apply a critical analysis of the tool to find the optimal one. The term assessment, test, and functional classification system are often used interchangeably. But in fact, there is a distinct difference between test and classification systems. Test or assessment refers to instruments that use a standardized procedure to measure a specific attribute within a given population. A test should have the ability to detect difference or change in the population with which it was used, and must consider ranging levels of ability within that population from high to low. The purpose of a classification is to group persons according to common characteristics. A classification is essentially a one-item test. Classifications should not be used to determine change, but rather to describe a group. For children with CP, we have 4 classifications. I think one that is most familiar is our gross motor functional classification system, which describes the gross motor function based on the use of mobility aids and performance in sitting and standing and walking activities. The manual abilities classification system describes how children use their hands to handle objects in daily activities. The communication function classification system describes the person's ability to interact in a communicative environment. And the eating and drinking ability classification system describes the functional eating and drinking ability in people with CP from ages of 3 years. Although we have 4 classifications currently for children with CP, we have a plethora of assessments available. So what happens? I appreciate this quote. We sometimes measure what we can measure because we can measure it. We do not measure what we should measure because it is more difficult and more complex. We then use the easy measure to infer things about the difficult measure. We need to be able to choose the correct tool based on a critical analysis of the tool. The ICF gives us a framework emphasizing the importance of measuring or addressing an individual's function, not only in terms of body function and structure, which is the anatomical construct of the body, but also in terms of activity, which is the execution of tasks of actions of an individual, participation, the involvement in life situations, and environmental and personal factors. Even though improved functional performance is the ultimate goal of most interventions, to know if the body function focused interventions give the expected effect on the targeted body area, the relevant body function measures need to be completed. However, in order to determine if that intervention influenced functional performance, it's imperative that measures covering the domains of activity and participation are also performed. Choosing the correct instrument may be a complex undertaking and should be based on a variety of factors: the content, the methodology, and the clinical utility. Let's begin looking at the content area. We must first ask, does the tool address the question that is being considered? In order to answer this question, we need to look more closely at the types of assessments out there. A norm reference test or tool compares individual characteristics of a group. So we're looking at, are they age appropriate? A criterion reference tool evaluates the performance against a standard. Do you want the tool to be clinical observation, where the therapist observes the child performing certain tasks, or patient or parent reported, which reflects the child or the parent's perspective and opinion on those assessed features? The tool can be individualized, as the child or parent offers their perceived performance difficulties and can help identify and self-identify their goals. When assessing hand function, another concept is the difference between the qualifiers of capacity and performance. Capacity is referred to the person's ability to evaluate or to execute a task or action on the highest possible level of functioning in a standardized environment, whereas the performance incorporates the real life and thus the social, the environmental, and the habitual aspects in completion of tasks. In other words, just because a person can use the hand when they're demonstrating to you within a clinic setting doesn't mean that that person uses that hand in typical tasks. Another question for the content area is, does the scoring algorithm provide the information that is desired? Do the scores answer the question? In order to be a useful outcome measure, it needs to be standardized and produce valid and reliable measures. Keep in mind that the psychometric properties are only applicable when the assessment is used with persons within the age and diagnosis that is intended for, and when it's used as stated in the manual. A final component for consideration is the clinical utility. What is the feasibility of using the tool for this patient population, for the administering therapist, or even for the clinic environment with which you're in? What is the cost factor of the tool, both for training as well as for the materials and administration? We understand that there is not a universal tool, but rather multiple instruments to consider in clinical and research situations. This slide shows the various assessments that have been categorized in the areas of ICF, an example of their relationships. Here we see the parent and the patient reported questionnaires share the family's concern that the child just can't keep up. The body function structure then shows that they have a decrease in their grip and pinch strength. We then move on and see in the activity and participation domain that these factors influence the way they handle bimanual activities. As today we are focusing on upper extremity and the single event multi-level surgery, we are going to look more closely at the Shriners Hospital upper evaluation, the SHU. Let's begin using our assessment outline and apply it to the SHU. Looking at the content. In regards to the ICF, the SHU is classified as an activity domain, as you are performing 16 everyday tasks. However, the SHU is unique in that it also assesses the body structure in the description of the position of the joint. It is criterion referenced, performance against a standard. The spontaneous functional analysis provides a spontaneity of use score using modification to the House scale. The dynamic positional analysis describes the position of joint in activity, such as flexion, supination, or extension. The SHU is capacity-based. That means in order to guide the treatment, the dynamic positional analysis is scored on their best ability to perform the task. Thus we can see what their potential for use is. Finally, the SHU is clinician observation, as the therapist provides 16 tasks for the child to perform. In regards to methodology, the SHU has evidence of validity and reliability. And for clinical utility, the SHU takes less than 15 minutes to administer, is video recorded, and can be scored at a later date. The manual and the training can be accessed online, and if desired, workshop participation is available. The cost factor for the SHU is free. The first page of the SHU records the history and diagnosis and any subjective information, including the goals of the family and their perceived limitations. Next portion is a recording of the range of motion. Only those areas not within functional limits are recorded. Tone is assessed through a modification of the Ashworth scale. And finally, ADLs are addressed from more of a participation aspect. Are they totally dependent, or are they trying to assist with independence? The second page contains the 16 tasks that are performed during the video segment of the SHU, with the spontaneous analysis describing how the SHU initiates use of the extremity with activities, the dynamic positional analysis that describes the positional alignment of each of the joints during the various tasks, and finally the grasp and release analysis with the capabilities for grasping and releasing within the given wrist postures. As we progress through this talk and through John Davis' talk, we will go more into depth with these scales. So overall, the SHU records active and passive motion of the affected limb. It describes the potential for use through using the spontaneous functional analysis and the dynamic positional analysis, and we assess the child's ability for grasp and release. Who is the SHU used for? Well, the child needs to be able to follow directions and have some ability to use that affected extremity. It has been validated for children with cerebral palsy, but it may have potential in populations with brachial plexus palsy or arthrogryposis, although need to proceed with caution as it is not validated at this time for those populations. The SHU has become a vital resource for systematically approaching the clinical decision-making process. Would the child benefit from therapy or from orthotics? Would injections be appropriate, or orthopedic surgery would be best to optimize the child's hand function? With a scoring system of spontaneity and positional analysis, the SHU has become an invaluable outcome measure. Now that we have applied our critical analysis to the SHU, let's see how the SHU is used in the following case studies. HK presents to us as a 12-year-old 9-month female with left hemiplegia. She has participated in therapy and upper extremity splinting, but she has not had any surgical interventions. She is a straight A student, a cheerleader, and she would like for her hand to be in a better position and be able to use it better. In order to assist with our clinical decision-making process, OT would be consulted at this point for a SHU. Let's take a look here at her video and her scores with the SHU. Notice how she is able to actively grasp and move her fingers, but her wrist is always in that flexed posture. The scores from the SHU reveal that she uses her hand as a stabilizer for some activities. She uses a weak grasp, and she has an overall spontaneous functional analysis of 62%. She keeps her wrist in a flexed position, as indicated by her wrist scores, but she does have some ability to bring that thumb out of her palm, as indicated by her thumb scores. She has a good grasp and release. These scores are then reviewed with the orthopedic surgeon. In her case, it was determined that she would benefit from FCU to ECRB transfer, Botox to the pronator teres, and Botox to the flexor pollicis longus. She had the procedure completed and was put into a long arm cast for 4 to 6 weeks post-op. And then she presents to OT. As we want to begin immobilization of the hand or arm, yet still need that protection, we will fabricate a resting hand splint with the wrist in 20 to 30 degrees of wrist extension. She'll wear this at all times except for bathing and exercises for the next 2 to 4 weeks, at which time she will start to taper out of wearing it during the day, but still continue to wear it at night for about 4 months post the procedure. We do typically fabricate a neoprene wrist orthosis around that 3 months of age for added protection when she is participating in more demanding activities. Now, that being said, we do have typical precautions. There were no resistive exercises until 12 weeks, no passive wrist flexion for 8 weeks, no composite full flexion or extension of the wrist and the fingers for 6 months post-op, and no contact sports or bicycle use for 6 months. When the child comes for the resting hand orthosis, we begin a home exercise program with the family. We begin with the basic range of motion exercises at each joint. We teach elbow extension, forearm supination, wrist extension, thumb radial deviation, abduction, and finger extension. At this point, we are gently gliding through these exercises, keeping the mobility. One area to monitor closely is the wrist. The intervention focused on gaining wrist extension. However, we have noted some patients develop extensor posturing, whether due to increased tone, increased tensioning with the surgery, or possibly overzealous exercising. If this is noted, we will begin gentle, passive wrist flexion exercises to neutral to make sure we do not remain only in that extended position. When addressing the finger extension, another area of challenge that may arise is a swan neck deformity. This deformity may be present before the intervention, or it may be unmasked after the intervention. Make sure that when you're fabricating that wrist orthosis or resting hand orthosis, that you keep enough flexion and curve to the finger pan to prevent the positioning of the fingers in this deformity when at rest. Once out of the resting hand orthosis, the swan neck deformity can be addressed conservatively at first with ring splints, but may need to be monitored with another surgical intervention after the recovery period is complete. At 12 weeks, resistive exercises are implemented. As the patient and family are proficient with the range of motion exercises, we now introduce the use of TheraPutty and TheraBand exercises to strengthen that tendon transfer. If working on supination, holding weighted cans can provide enough resistance. Once the incision is healed throughout the active and passive range of motion exercises and the resistive exercises, scar massage should be taking place. Applying enough pressure to blanch the skin, move in a vertical and in horizontal, circular, and crosshatch motions. It is recommended that scar massage be performed 3 to 4 times a day. Let us now take a look at our case study now that she has completed her surgical intervention and the rehab process. If possible, we perform the shoe 9 to 12 months after the surgery. Here she is with the same activities, but note the position of the wrist. And here we can see how the shoe scoring is able to capture that change. Her spontaneity improved from 62 to 78%, and we note that she is now consistently using it as an active grasp. Her positional analysis went from 65 to 92%, and we note that her thumb is now used in open position, and her wrist has much improved, coming into more of an extended posture. As always, her grasp and release remains at 100%. Our next case is RG, a 17-year-old male with left hemiplegia, who received the same protocol of assessment of the shoe. His presentation and scores show no active grasp. (9% for a spontaneous functional analysis, with 6 of his tasks not even bringing in that hand to participate with the bimanual activity. And we notice his positional analysis is at 51%, with significance in no movement of the fingers, poor wrist and forearm positioning. He does not have the ability to grasp or release in any position. This patient underwent a wrist fusion strategy with a proximal row carpectomy, the FDS fractional lengthening, and an EPL rerouting. In these cases, the patient begins with a long arm cast for 6 weeks post-op and then receives a short arm cast. And so they're casted for a total of 10 weeks. They then present to OT. We fabricate the resting hand splint, molding the wrist position in that fused position, and being wary of the fingers and the risk of the swan neck deformity. We position the fingers at MCP of 60 degrees of flexion and the IP at about 10 degrees of flexion, keeping a functional curve to the digital pan. The resting hand splint can be discharged around 4 months of age or 4 months post-procedure, transitioning to the neoprene orthosis that should be worn for protection for up to a year. Precautions remain similar, with no resistive exercises until 12 weeks post and no contact sports or bicycling for 6 months. The home program for active and passive range of motion is started when the patient is placed in that resting hand orthosis. The wrist is fused, but the joints around the wrist need to be moved. Elbow extension, thumb abduction, finger flexion extension are performed with gentle movements at first. At 12 weeks, the resistive exercises are begun. If the child has grasp abilities, you can have them squeeze foam, a rolled up washcloth, or theraputty. If they're able to move their fingers, then the use of putty or stretchy bands provides varying degrees of resistance. As stated with the tendon transfers, scar massage is indicated once the incision is healed. Here is our patient 1 year post-surgical intervention. With follow-up rehabilitation, note the position of his hand and the increased use. Through the use of the shoe, we have the effects we saw on the video quantified with changes noted in his SFA from 9% to 33%, and he is now using it as a passive. He puts things in his hand versus totally neglecting it. His positional analysis has improved from 51% to 79%, and we note improvements in his wrist, now being in the fused position, which allows him to use the ability to use his fingers and to move them. In review of our objectives, the use of objective measures is paramount in clinical decision-making. Determining the best assessment requires understanding of all components of the IF. A critical analysis of the tool prior to use should include understanding the content, the methodology, and the clinical utility. We then applied this analysis to the shoe, understanding its role in the clinical decision-making, in its ability to describe the spontaneous use of the involved upper extremity, as well as the dynamic positional analysis of the joints of that upper limb. With an understanding of the shoe, we were then able to look at the 2 case studies, reviewing the rehabilitation of the various interventions and seeing how the shoe, through the scoring, is able to quantify the changes we saw in the pre and post videos. Thank you.